I intentionally didn't prepare a PowerPoint slideshow just because it tends to come out so versed and pre-planned, and I really wanted this to be more of a passionate appeal to everybody that's involved in the treatment and support of our community members when it comes to substance use disorders and specifically opiate use disorders. It's a huge problem, and it's growing, unfortunately, by leaps and bounds. So I printed off on the scope of the problem, the treatments that are available, and raising the question of why we're losing ground when it comes to this problem rather than gaining ground. And to that point, I'd like to talk a lot about my experience and our office's experience over the last 10 years in Tooele. So I have Mike Neff, who's our therapist and clinical director, and Sylvia, who's been our program coordinator for much of that time, and Sylvia knows everybody. And without her, we would be dead. So does anybody know what portion of the general population at any given moment has a substance use disorder, meaning they meet the diagnostic criteria for a substance use disorder? Hazard a guess.
Almost half.
65% of the population?
I don't know.
Oh, I hope not.
I don't know.
30%.
It's about 10%. So if we look at number of people who have used any substance, that number can go very high. It's pretty close to 60%. But just using a substance doesn't qualify for having a substance use disorder, right? That requires that you have some tolerance, withdrawal, and a number of other diagnostic criteria. 10%. So population of Tooele County right now, what's that? About 70,000? Yeah. So we have 7,000 people roughly with a substance use disorder in Tooele County. What treatment options do we have in Tooele County? Me.
Very little. Warrior
Right.
Spirit.
Warrior Spirit now.
Warrior Spirit.
Bonneville.
Valley.
Valley Behavioral Health. That's all I know.
Clinical consultants and
Mater.
Mater.
Does clinical consultants have a provider that's prescribing medicines?
They do. Yeah.
Okay.
Yeah.
Okay, we have YPR and other 12-step fellowships that are at least there to aid in the substance use people, just to let you know. Okay, thank you.
We do have some resources that are absolutely necessary and integral to the treatment and support of our residents.
We have a detox center.
No,
Okay.
we don't. Not only do we not have a detox center, we can't detox patients in our hospital.
Yeah, they send everybody Salt Lake.
So one of the most mind-blowing figures, and there's a few charts that represent it in the packet that I gave you, and if you're online, this is available online, and I'll share that. I'll have someone share the link with you so you can also look at it. Tooele County ranks near the top of the state for how many residents have a substance use disorder, but we rank dead last in the care that we offer those people, so access to care. So almost the most patients and the very last access to care, which is right. And there's probably a number of reasons for why that exists. I think our proximity to Salt Lake makes it very easy to assume that we can just use Salt Lake's resources. That has not ever happened. And in my experience, that barrier, which is what, a 30-minute drive, is enough to block access to care very significantly. We often have patients who need treatment that we cannot offer them, and we struggle to get them where they need to be. Historically, and this is changing just this year, There was one facility that had the contract for Tooele County Medicaid when it comes to treatment of substance use disorders. And so if an outside physician wanted to refer a patient for treatment, they had to get kicked back to that facility and then triaged and sent out, which was another significant barrier to getting people the help that they needed. And so Sylvia and I have spent countless hours over the last 10 years trying to devise workarounds to get people to treatment. We've sent people by taxi that we paid for. We've run as much through medical benefits as we can so that we could bypass the Tooele County Medicaid restrictions when it comes to treatment of mental health. But we've never been able to achieve the impact that is needed. And so I'm so happy that we finally have this group of people, and everybody brings a different perspective, different tools, different resources to the table. And I think the time is right and desperately needed to make a difference in Tooele County. If we look back at the treatment options for Tooele County, we came up with maybe 5 or 6 options. So at max, if each of those people were treating 100 patients, that puts us at about 400 or 500, right? But we just decided there's probably around 7,000 people in Tooele County with a substance use disorder right now. Even if we maximized all of those facilities, we could not meet that need.
Just stand closer to the
Sure.
computer, just so it catches your voice. The
Yep.
owl isn't quite doing a good enough job so that they can hear.
No problem. When it comes to treatment of opiate use disorder, it is not very complicated. It seems very scary, and there's a lot of historical and personal baggage when it comes to treatment of addiction. But there's really only 2 things that we can use to treat opiate use
You
disorder:
need to tune into this.
medications and therapy, right? Therapy services. The guidelines for treatment that were just reposted the end of 2020 by ASAM are pretty clear. Medications make a bigger difference in the treatment of opiate use disorder than anything else. Everybody who has an opiate use disorder should have the opportunity to get one of 3 medicines. And each medicine comes in different forms, but they all have their own limitations, benefits, and restrictions. So first medication is extended use naltrexone called Vivitrol. It's a monthly injection. It blocks opiates. So that's awesome, right? If you're stuck using opiates every day, and I can give you a shot that blocks opiates so that your opiate use really has no benefit, you're much less likely to use opiates. The problem is you have to be opiate clean for 14 days before I can give you the shot. How do I get you to be opiate clean if you're going to go through the worst withdrawal you can imagine for those 14 days? And I can't even admit you to our hospital to take care of you while you go through that. Ask them.
Why do you have to wait 14 days?
It's an opiate blocker. So if you have any opiates in your system, whether that's pain medications or heroin, and I give it to you, you'll go into immediate severe withdrawal. And because it's a long-acting shot, that will be a prolonged, miserable experience. We can detox people and get the opiates out of their system in a more comfortable manner, but that requires inpatient facility, which we don't have in Tooele County. So when patients show up and they want treatment for opiate use disorder, first thing I talk about is Vivitrol. I give everybody an option and a chance, and we talk about we can do an outpatient detox. There are some medicines that can help. The very best medicine that was approved a year or 2 ago is not covered by any insurance that I'm aware of. We can use some stand-in medicines, and we can treat the symptoms, and I can help them limp through that. And if I can get them even to 10 days, I'll usually be willing to start the medicine early. I think I've done that twice in 10 years. I think 2 people have achieved that.
What was that medication that you said it's not from the Rangers?
The generic is fexidine. I have to look it up. It's similar to clonidine. but it doesn't have as many side effects, namely severe hypotension or low blood pressure when you use it. And there was a study that came out a couple of years ago. They used a combination of this new medicine, Lucamyra is the brand name, along with oral naltrexone, and they could detox in 5 days, and then they could start the Vivitrol on day 6 without any negative side effects. And I've yet to try that because the Lucamyra is expensive and insurances don't cover it. So if they don't want to detox or can't detox to get to the Vivitrol, then we talk about 2 other options. Buprenorphine, which could be called Suboxone, Subutex, a few other names that are less common, is available for outpatient treatment from community physicians like myself. Sorry, I never told you I'm a family doctor. I'm not board certified in addiction medicine. But that was the beauty of buprenorphine and Suboxone, is you could go through extra training, and then the DEA would give you a special license to prescribe buprenorphine. First off, you could treat 50 patients and then 100, and then you could apply to treat up to 250 patients. That was the max, which we can do. I don't think we've ever topped out. At most, we've had around 200 patients at any one given time at our clinic. But that was a barrier, right? So there was one doctor in Tooele who was waivered and willing to prescribe forever. Valley Mental Health was doing it for a little while through their mid-levels, but that's been hit or miss. And then I think for a brief period, one of the U of U providers was waivered and prescribing buprenorphine. But it's been very hard, and access has been very limited in Tooele. And then there's methadone. And methadone has been used far longer than buprenorphine or Vivitrol for the treatment of opiate dependence, but that has even more restrictions. It can only be prescribed at a federally licensed opiate treatment center, and we don't have a methadone clinic in Tooele County. Oftentimes, you have to be there, between 5:30 in the morning and 6:30 in the morning to get your daily dose of methadone. And so you can imagine driving 45 minutes to get your medicine, 45 minutes back if you're a Tooele County resident. It does not happen very often. After the medications, there's therapy, and therapy can take lots of different forms, which we offer some forms at Bonneville Family Practice. Valley Behavioral Health offers more, and now we have Warrior Spirit, who has an inpatient treatment program and an outpatient treatment program. So there's probably better access to therapy than anything else. We also have a lot of community physicians. 12-step programs or peer support programs would fall into that category, and we have access to those in Tooele County as well. But the new guidelines and the current evidence is very clear in saying therapy without the option of medication is not enough. It is simply not enough. Everybody should be offered therapy. It should not be required. If a patient comes in for treatment of a substance use disorder and they don't want to participate in therapy, give them the medicine. The medicine has far greater results and benefits than the therapy ever will. But then we run into the stigma of the medicine, right? What are your thoughts on the use of methadone or buprenorphine, Suboxone for the treatment of heroin dependence?
I know just for my law enforcement friends talking about it.
Oh, I love
it's
them.
ridiculous because they're treating out one opioid for a lesser form of opioid.
Right?
So it's just getting ridiculous in my head because I'm like, at least it's a medication way to take your people off and get them functional members of society.
Yeah. So that's probably the number one stigma is, well, you're just trading one thing for another, right? I'm not aware of any of my patients stealing their neighbor's lawnmower and pawning it to get their Suboxone. So if we talk about the stigma, especially with methadone, but to a large extent with buprenorphine or Suboxone, the problem is real. I see it a lot with law enforcement when we work with them. But I see it a lot with new patients, spouses, employers, almost anybody that we work with, ER physicians. It really is a struggle. But if you take a step back and you look at, oh, go ahead.
Well, I was just curious if it was a lack of education, like maybe they're not educated that time. They can just think, oh, it's, you know, using what else.
I think so.
And
Well,
just repeat what she said, because they can't
oh,
hear online.
so if you're online and you couldn't hear that, it was brought up that it's probably from a lack of education, that we're replacing one substance with another substance, and then calling that better. And that's scary, right? And we should think about that, because don't forget, this crisis overwhelmed us because of doctors like me and the medical community. So we had all these patients that were in pain, and for a number of reasons, we decided nobody should be in pain. We're going to treat their pain. Don't let anybody hurt, right? It's the fifth vital sign. If they're in pain, you're not doing your job, give them some pain medicine. It's fine. It's not addictive. If they're taking it for pain, just treat their pain. So we just started handing out mass amounts of pain medications. This was all kind of coming to an end right when I was entering training, but I still saw it to a great extent, which is what led me to doing what I do. So we gave all these patients medications. Turns out, yes, you can get addicted if you're taking it for pain. And very quickly, you could have chronic pain and an opiate use disorder or an addiction disorder. And the two go hand in hand very frequently. About 80% of people who end up suffering from an opiate use disorder started with pain medications that were prescribed for acute or chronic pain by their doctor. So
just real quick, could you give a brief primer on like what the line is between an opioid dependence and opioid use disorder?
Yeah. I'll get right to it. And if I don't, just start waving your hands.
Okay.
So based on faulty logic and a misrepresentation of science, we thought it would be great to give all these patients pain medications, which kind of started where we're at now. So we should ask, are we doing the right thing by giving people with opiate use disorder or addiction another opiate, right? Which is methadone or buprenorphine, or are we just propagating that same cycle that got us here in the first place? It turns out we're not. I think we are doing the right thing, but we should ask that question.
And that wasn't my one. I wonder, like, the stigma of it, like, people like always see that no one's going to have to decide you are, you know, together, like, you right? And to become the benefits of it, you know, you're a functioning member of society on this versus, you know, like maybe there's just.
You never about clinical, there could be a own stigma within the prescriber, or maybe a malpractice aspect to dealing with the
Oh, yeah.
issue, addressing the issue.
Yeah, I can't, almost every conversation that I have with my peers is, you know, oh, God bless you for doing that. Like it's miserable to work with these guys, right? Like it's not your neighbors, your kids, your relatives, your coworkers. 1 out of 10 people have a substance use disorder. 1 out of 10 people are not miserable to work with. It's just normal people, right? I see a lot of people that are functioning addicts, and most people don't know. So there's a lot of stigma that goes along with that, and education and awareness and just treating it normal are exactly what has to happen. So I was coming back to the difference between substance use disorder and dependence. So I think you can define dependence 2 different ways. On one hand, it's synonymous with a substance use disorder or addiction. On the other hand, we're referring just to physical dependence. If I gave anybody pain medication for a significant period of time and you took it on a regular basis, you would develop physical dependence. It's the body's response to having that medication. And when you take it away, there's a withdrawal symptom. So that's physical dependence. That does not qualify as a substance use disorder. It's one criteria for that. But the substance use disorder or addiction, you've got to have the dependence, the physical dependence or withdrawal. You have to have tolerance, meaning you're increasing the amount that you take over time to achieve the same result as when you started. And then you have to have some biologic, social aspects of disease, right? Missing important things, doing things that are not socially acceptable and it's related to the substance use, doing it in an unsafe manner, like when you're driving. So there's more to meeting the criteria for a substance use disorder. So speaking to education, I think that's exactly what has to happen. And one of the benefits of being a family doctor who treats patients with substance use disorders is I can enter that conversation like I just told you, you have diabetes, right? And I get a lot of patients who come to me with chronic pain, which I really think is a substance use disorder, or they know they have a substance use disorder and that's why they're there. And it's the first time anyone's ever sat down with them and treated it like a chronic disease, just like I would high blood pressure, diabetes, high cholesterol, heart disease. All of those issues are going to last for the rest of your life. So is a substance use disorder. All of those issues are going to be controlled at times and out of control at times, just like a substance use disorder. All of those issues are caused by primary functional and behavioral change of your body, right? Diabetes, either your pancreas isn't working or downstream organs aren't using the insulin appropriately. And all of them have a treatment. If you have diabetes, you're probably going to be on the medications for the rest of your life. You could make some changes and have a chance to stop those medications and keep your disease in remission as long as you maintain those changes. Same thing with the substance use disorder. I have a lot of patients who will probably take their buprenorphine for the rest of their life. I have some of them who make changes, their disease is in remission, and as long as they maintain those changes, they can keep their disease in remission. But if something flips or changes, it will come right back out. But if we view it as a chronic disease instead of a crime, which we've been doing since the war on drugs started in the 80s, then our perspective is totally different, right? So now it's not the patients that nobody wants. It's not just criminals, and it's not just bad choices and being a shitty person. It's a chronic disease. Anybody can develop it. 8 out of 10 people developed it because their doctor gave them medicines that were probably warranted at the time. But in certain circumstances, it changes the physical makeup of your brain and the function of your brain. So now you have a diseased organ that's not behaving appropriately. And part of the problem with that is it disconnects from the frontal lobe. So now you can't plan very well. You can't decide what's important and not important or prioritize very well. Your emotions are dysregulated from reality. And you have this insatiable drive to reach a steady state where things work normal, but that is only happening when an opiate is present, right? And just taking away that opiate doesn't matter. We've done countless studies where we've taken patients, we've sedated them with anesthetics, general anesthetics. We've let them sleep through the withdrawal. We've woken them up and said, congratulations, you're sober. See you later. None of them are still sober 5 years out. It doesn't work. Just taking away the substance and overcoming that physical dependence does not work. Those changes in the brain and the function and the structure of the brain persist, and they probably will persist forever. Not only did a lot of times that start with your doctor, but some of it is inherited. Some of it is waiting in the background, and at any moment under the right circumstances, those changes that promote addiction or or substance dependence can come out. Genes, a lot of them can turn on or off. What are the things that turn those genes on? Social stress, poor nutrition, lack of exercise, any exposure to certain substances, including alcohol, cannabis, and nicotine. So you take all of our teenagers. Who has teenagers? I do. Nate knows them. So their entire being is trying to separate from their parents, prove that they're an individual. They have no sense of harm or risk. And so that's the prime time to try smoking or vaping now, right? Try cannabis, try drinking. And if they have those genes can turn on with surprisingly little exposure to those things. Think about our other patients or community members who are stuck in poverty or don't have good nutrition, have very high stress or dysfunctional homes. That can activate those genes. So those people, as soon as they have a chance for repeated exposure, are primed to develop a substance use disorder. And that's where prevention, I think prevention was this side of the table, can play such a big role. That is absolutely the single best treatment for this problem, is to try to prevent it, to educate the community in the first place. But then on the flip side, once it's there and we know about it, we have to destigmatize it, right? You should be able to go to any doctor and tell them what the problem is, and without judgment or shame, get treatment for that. If they can't offer it there, they can get you to the right place, right? That's what I do. If you come in and you have a nasty broken leg with bones sticking out of it, I don't do that, but the orthopedic surgeons do, and so we get you there. But that's not what happens with this problem. Too often they come to their doctor, they tell them what the issue is. They might not say, you know, hey, my name is Pat and I have a opiate use disorder. They might say, I have chronic pain and I ran out of my pain medicines early and my doctor won't give them to me, right? But that is a great chance to talk to them a little bit more and figure out what the true issues are and help them get the help that they need. One of the biggest issues here is we don't have the help that they need. And that's what we really need to change. And that's what I was hoping our discussion could be about today, or moving forward, because we have so many people with diverse backgrounds. Some things are changing quickly, which is wonderful. They changed the rules with prescribing buprenorphine or Suboxone, so you no longer have to do the extra training, which honestly is not very hard. It's 8 hours. You can do it online, and then you get your special number and you can prescribe it. But now our providers, including mid-level providers, can prescribe buprenorphine, Suboxone up to 30 patients without getting that waiver or that doing that extra training. And that is fabulous, because that's one step closer to patients being able to go see their doctor and starting to get help. The hospital, Mountain West Medical Center, has been awesome with this. So we met with them a year ago, maybe 2 years ago, and the pharmacist there, it was kind of his baby, but they started a program where if patients show up to the emergency room, they're in withdrawal and they have an opiate use disorder, they can start the medicine in the emergency room. They can give them their first dose of their medicine, they can give them my phone number, and as soon as we open the next day, they can walk in and we can continue their treatment. Because the ER catches a little bit of everything, but especially that. When patients don't have any other option, that's where they go. And so that's been an amazing program. And there was a lot of stigma and mixed feelings with the staff at the hospital. And the more that we just talked about it, it blew my mind how easy it was to overcome. So as you're interacting with your family, your friends, the community, other providers, law enforcement, have that discussion with them. Like, hey, you know, not all these guys chose them. And some of them make some bad choices, but there is treatment for that. And if we use the medicine correctly, we're not simply replacing one thing with another. Buprenorphine especially behaves vastly different than oxycodone or heroin. So it binds to the same receptor. and it does not like to let go. But it doesn't cause euphoria or feeling high if you have a tolerance to opiates, which is kind of the one requirement to get that medicine, right? You gotta have tolerance. So you can give it to them. They could take as much as they want, and they cannot get high. After taking about 24 milligrams, maybe 32, depending on your biology, taking more than that does absolutely nothing. Nobody's ever overdosed on buprenorphine or Suboxone unless they were opiate naive, meaning they didn't have a tolerance, they were a child, or they were mixing with something else like alprazolam, Xanax, lots of alcohol, heroin. But if you take it, you could, and you have a tolerance, you can take as much as you want. You won't get high, you won't overdose. Just those two things alone make it a perfect choice for the treatment of opiate use disorder. Suboxone doesn't. Oh, so the question was brought up, doesn't it work for alcohol as well? And buprenorphine, which is the active ingredient in Suboxone, does not. Vivitrol, or extended release naloxone, does. And so that's the one medication that has an FDA approval for treatment of alcohol use disorder and opiate use disorder. Yes. Yeah. I can honestly say I will treat anybody with anything. I spend about half my time working with patients with opiate or substance use disorders, whether it's alcohol, methamphetamines, opiates, could be heroin, pain pills, and then a little bit of random other stuff. And then the other half of my day is everything else. So those two characteristics of the medicine make it wonderful, but the fact that it won't let go of the receptor means even if you do relapse, it's kind of like the Vivitrol in that it blocks the opiate from binding to the receptor because the buprenorphine's already there. And so you don't tend to get the benefit or the reward from the drug use as long as the buprenorphine's there. So you could, in theory, get the buprenorphine to go away and then relapse, but it stays in your system forever. It takes weeks to get buprenorphine all the way out of your system. Meanwhile, every day you're getting sicker and sicker and sicker. And so we can get people on a medication that totally stops withdrawal, reduces cravings, it's safe, and it physically blocks the effect of their substance or drug of choice. It and methadone reduce crime rates, hepatitis C transmission, HIV transmission. It improves almost any measure of life that you could look at, right? Job retention, having insurance, family dynamics. So we get all of these benefits with that medication. The only part of the medicine that crosses over with the one we replaced is that it does bind to the opiate receptor. It does.
So with some people thinking a methadone clinic might be an important addition to medication for opioid use disorder, like with how great Suboxone is, why would you even want methadone?
Because people come in all shapes and sizes, right? And so most of my experience is using buprenorphine Suboxone. I was the medical director for a methadone clinic in Salt Lake for a number of years before we started in Tooele. And not everybody responds well to buprenorphine. We're finding this more and more as illegal fentanyl shows up in the drugs that people are using, not just in heroin, but getting pressed and packaged to look exactly like oxycodone. A lot of my patients that are using methamphetamines are testing positive for fentanyl. And even some of the cannabis products are testing positive for fentanyl. So it's making its way through everything, which is a problem for a number of reasons. But one issue is buprenorphine is not nearly as potent as a full opioid. And you may not be able to achieve resolution of withdrawal with buprenorphine if you have a high tolerance to fentanyl. Some people are allergic to it. It tastes horrible. So you put it in your mouth, it dissolves, and then you absorb it through the tissue in your mouth. That's how you take the medication. It's not a pill that you can just swallow. And some patients really can't tolerate it. They throw up every time they take it. And so we have methadone, which is a full opiate agonist or a full opiate. It's very similar to morphine, oxycodone, hydrocodone in the way that it behaves. And that's why it has demanded more scrutiny and becoming a federally licensed opiate treatment facility. But we still get a lot of those other benefits. Number one, it lasts very long. So you can take it once a day instead of pain pills or heroin that you have to take repeatedly throughout the day. And you can't just stop taking it one day, use drugs the next day, and then come back. It's still in your system. It still has a higher affinity than the drug of abuse. It still reduces cravings and withdrawal symptoms. It still reduces crime rates, disease transmission, and all of the negative aspects that we associate with substance use disorders. So it's a wonderful treatment, and it should be available to everyone. Nate has and Sylvia, and to a much lesser degree myself, have been looking at what it would take to bring that to Tooele County. I think we're probably the last stronghold in Utah that doesn't have access to a methadone treatment facility. And I think the biggest barrier is probably the stigma or well, you're just replacing one thing with it, right? So we do have to overcome that. And I think having an honest discussion and really campaigning for the treatment of substance use disorders in our community is how we get around it. So that's enough me talking at you. Ask some questions.
I have a question.
Yep.
So a few years ago, Vivitrol was not necessarily a primary source of use for women in pregnancy with substance use disorder. Is there any other new studies related to Vivitrol being used with women with substance use? Obviously, they use the typical methadone and Suboxone for MOUD and mothers to be, but is Vivitrol at all anyone?
I'm not aware of any new studies promoting its use. And I think my biggest hesitation would be, I'm giving you a long-acting medicine that blocks pain medicines, and then you're going to have a baby. Yeah, yeah. But I would imagine that there are some studies looking at its use, and I think it would be effective. I'm not aware, and that doesn't mean that it doesn't exist, but I'm not aware of any strong evidence that the medicine itself causes harm to baby. For a long time, and we still do typically stop Suboxone and switch to just buprenorphine during pregnancy to limit exposures to anything we can during pregnancy, but it's not because there's strong evidence that the naloxone and Suboxone causes problems. So that's another misconception that I end up talking to patients and families a lot about is it's the naloxone and the Suboxone that blocks the effect of heroin or other opiates, which is really not true. You do not absorb much of that through your mouth when you take Suboxone. It's really there just to keep people from misusing the medicines, trying to dissolve it and inject it primarily, because you don't absorb it through your mouth, but if you inject it, it causes immediate severe withdrawal. So it's really just a deterrent to try to keep people using the medicine. Even if you're getting Subutex or just buprenorphine, it still will block the effect of other opiates. One last thing to talk at you about for medicines. A couple of years ago, a new form of buprenorphine called Sublocade was approved, which is an extended release injection. So it's a once-a-month injection, similar to Vivitrol. And you have to be stable on Suboxone or buprenorphine for at least a week, and then your dose has to be within certain parameters, but almost everybody falls into that criteria. And we can give you the shot and you're fine for a month, which is amazing, right? Because that means if you show up to treatment and then your family kicks you out and you lose your insurance, you don't lose your medicine immediately. So you can come back, we can figure it out, we can find a way to keep you on that medicine. The other thing that I just love about it is you can't sell it or trade it or do any of the other things that some people do with their Suboxone or Buprenorphine, right? It's a shot, it's yours, it's there. And then perhaps the best benefit of this is a lot of patients will end up on medicine long-term simply because it hurts too bad to get off, right? Every time you see your doctor, they lower the dose and you know you're going to be sick for a week and you're going to do that every 2 to 4 weeks. That's a miserable process. But with Sublocade, because it's so long acting, after we've done 6 or more injections over 6 months, it'll be in your system for 12 more months. We've had patients come back a year after their last shot and their UA still shows buprenorphine. But your body metabolizes it so slowly that, you know, if it's there for 12 months, every day there's 1/365th less than the day before. That's such a minute change in the concentration of medicine in your body. You don't feel it. So you get your shots, we see how you do. You won't have withdrawal. It's not the same as the rapid detox because your brain has done some of the healing when you were on the medication. Hopefully you had an opportunity to participate in therapy, peer support, community programs to make the changes that you need to stabilize your disease, and you can continue those as the medicine slowly wears off over 12 months. And then we can decide if you can move forward in remission without medication or not. Some patients can't. They come back and have to start over again because they've started using drugs again. So every patient is different, but it gives people an opportunity to get out of that physical dependence trap that we've never had before. And it's covered 100% by Medicaid. Thank you, Optum. So that was another huge barrier was even if we wanted to put people on medicine before, we had to get it prior authorized with almost every insurance, whether it was public or private. That takes time. They're in my office throwing up on my floor right now. So they did away with the prior authorizations. Almost everybody has, which is phenomenal. And I'm really not aware of any insurance programs right now, except PEHB maybe, that doesn't cover Sublocade, which is amazing because I think that's the best tool we've ever had to treat opiate dependence. It's a phenomenal medicine and a huge advancement.
So that was one of my questions about as a community, as a consortium, trying to address the substance use issues and make it better for our community. What needs to change? What needs to happen? And so I was actually wondering if insurance and funding were parts of the issues. But you said we don't have a detox center. Is there anything that needs to change to address that? Like, what do you see as the big needs and changes in the community?
Yeah, I think at a bare minimum, if we kind of start at the beginning of treatment and work through it, we need a way to detox patients in our hospital. That means that we probably need to find and hire a physician who is board certified in addiction medicine and can get those privileges and support at the hospital to admit patients, treat them, and then help them plan what they're going to do afterwards. Once they have gone through that, if they need it, a lot of patients, especially for opiate dependence, don't need that. Some do. Patients with alcohol use disorders have to have that. I mean, I don't know if you've had any family members or friends that have struggled with severe alcohol withdrawal. It is terrifying and it can be fatal. So we need that. Once we have that, we need an option for treatment afterwards, right? So we have our flavor of outpatient treatment for substance use disorders. Valley Behavioral Health has their flavor for treatment. And then we have community physicians or community therapists and a few other clinics that I'm not real aware, I don't know too much about them, but they have their flavor of that. I think the more options we have, the better. We need to treat 7,000 people at any given moment, right? We need as many of those options as we can get. And the more flavors that we have, I think the more likely patients are to find the one that works for them. Some people need a lot of structure. Other people hate being told what to do. And so we really need to have options for them. Once they're stable and can participate in outpatient treatment, we need sober living facilities, right? We have a lot of patients. We have one patient right now. Every day I ask Sylvia if he's still alive. He's homeless, he's struggling, he's gone through the worst, most horrendous things in the last 3 months I've ever seen. In and out of hospitals for injuries and infections, and on and off of his medicines, both for substance use disorder and other physical and mental health issues. And it's horrible. And we did get him into a treatment center, the only one that would work with the Medicaid coverage that he had, that had room for him. And it wasn't his flavor. He left after 3 days. So the more options we have, the better. Not everybody can just jump right into outpatient treatment, right? Some people really need to be in a safe place where they do not have access to drugs. So we need more residential treatment facilities. We need day treatment facilities. We need more intensive outpatient treatment. We have tried several times to work through those steps and offer different levels of care, and it's been too hard with insurance companies. We couldn't do it with Tooele Medicaid, which is changing. And then private insurance companies would tell us, our panel for mental health treatment is closed. There's too many people in your area that do that. Why? It's 5 miles to West Valley. You got to drive all the way around the mountain, and people won't do that, but it's 5 miles to West Valley, and there's too many programs there, so their panel's not open for new providers. And we're slowly getting through that so that I hope we can offer more services. But even if we do, we cannot offer services to 7,000 people. So we really need to find, recruit, support all of those different flavors of treatment. I think a methadone or an opiate treatment center is vital to that. A lot of people thrive in showing up every day, getting their medicine, walking through the door further if they need anything else, right? If they don't that day, then they can leave and go to work. But you can get so many resources there, and people could show up any day, anytime to start. It doesn't take a referral or any special magic. They just know I could go there and they can help. So that starts to take the burden off of the emergency room at Mountain West Medical Center and all the community physicians who aren't equipped to help with that.
I just wanted to. So I've been working on harm reduction for the last. Part of that, but in getting our community specifically to kind of come around and accept syringe exchange and naloxone to prevent opioid overdose from taking so long.
Yeah.
And I think part of it is just giving them the education and the time and get a greater understanding. And I do feel like, for the most part, the community provides part of having that be along with some of those other things you mentioned. One other thought, and I just looked at the agenda, is we provide Narcan to every inmate leaving the Tooele City Jail, and I think it'd be awesome to also give them a Vivitrol shot or
Yes.
Something like that.
I think that would be amazing.
We could look at taking that further.
Well, I think there's a number of things that you could look at when it comes to incarcerated individuals and how we handle substance use disorders. And this goes back to that whole doing drugs is a crime and you need to be punished stigma that still infects our community and society, right? Number one, do they have to stop their buprenorphine or methadone? No. There's a number of studies where prisons and jails have continued methadone and buprenorphine treatment through an inmate's residence there, and it works great. We see the same types of improvements that we see in the community at large. Less crime, less violent crime, less overdose deaths, less disease transmission, because believe it or not, you can get drugs in jail. And so we don't have to make people detox in a cell and just sweat it out and be miserable. We could do that. And then when they're leaving, yes, we could give them Suboxone. That just bought them 30 days, right? To get in and continue their treatment when they're released from jail or prison. Or better yet, if they do detox in jail, either because they were forced to or they decided to, everybody with a known opiate use disorder in their whole life should be offered free Vivitrol before they walk out that door. We see a lot of patients who end up going to jail or prison. They detox, they do okay, they get out, and then they come see me because they're dependent on heroin. And so, yes, I think offering Vivitrol to the appropriate people before they leave would be a priority.
Well, I know so many people have told us when we've done different focus groups that that's the only time or way they've been able to leave is by going to
Yeah.
prison. But then I would guess down the road, they're probably.
Unfortunately, some people need that flavor of treatment. And I do have some patients, when I find out that they're in jail or prison, I'm like, oh, thank you. We were not going to disrupt that cycle any other way. But if we don't follow through and give them the medicine and the treatment that they need before they walk out the door,
Right.
they're just going to start over.